Hi team, welcome to our conversation on SARS-CoV-2 or COVID-19. We're going to dig deep into this powerful pathology. As we dig in here, I do want to kind of gently give you almost a content warning. This topic might be kind of triggering for you given that you've had to live through this pandemic for the past several years and probably experienced many effects of it. So if you need to take little breaks during this, I highly recommend that. Remember your skills for taking care of yourself and remember that what you are doing matters. And this is something I've said to a couple of you. Sometimes learning about conditions that hit really close to home can kind of like be sort of a button push situation, like it makes you feel really sad and kind of anxious. And sometimes I think I feel that way too, like a condition that a patient has, I know because a family member had it. Whenever this sort of thing happens, I take a deep breath and I center myself in my why, which is I'm here because I want to be. It's a privilege to be here. I'm good at what I do and I'm going to make things better. I'm here to serve. So you pull in that servant heart and it lets you jump into this challenging science, okay? All right, here we go. So let's start at the beginning. What is a coronavirus and what's with the name? Maybe you know some of this material, maybe you don't. I have updated it as of January 2024, so it's the most current I can get it such that you're listening to it now. Well, coronavirus is a class of virus. The scientific name of COVID is SARS-CoV-2, and the name, of course, comes from the type of condition that it is, which is a coronavirus, and the year in which the outbreak began. How did we get here? Well, at this point, you may know that this is a zoonotic disease. It originated in animals. People were living close to animals, and basically contact occurred. We're probably going to see more incidents of this happen as we experience more changes with our environment. I know that another example of a really common and rising in incident zoonotic disease is Lyme disease, one that you may be more familiar with if you've gone hiking or you have a pet. Okay, so COVID. It's famous for the crown-like appearance of its spike proteins that you can see in electron microscopy images. This type of condition is in the same class as SARS and MERS, which you may remember from the 2000s. Note that RNA-type viruses have high mutation rates. They're capable of mutating themselves on the order of months. In other words, it looks one way in January, it looks a completely different way by June, which is absolutely something we've seen over the past few years. The incubation period of alpha, the first manifestation of COVID, was about 3 to 14 days with 5.1 being the median, and incubation was around 3 to 7 days. That's still fairly true, actually. And ultimately, this condition ended up on all continents, including scientists in Antarctica. So we're going to go into the pathophysiology of this condition. This slide is here just to give you an overview. Let's jump in a more detailed way. Okay, so similar to our conversation when we were talking about immune conditions with HIV, HIV comes up to a cell, as do other RNA-type viruses. It finds an access point, takes over the cell by injecting its own genome. The cell produces more of that particular virus and then expels it. That's kind of similar here. This time, the COVID virus accesses via the ACE2 receptors to attack our alveolar cells. In the alveolar cell, viral RNA is replicated and the host cell keeps spewing out more of that viral protein. While the alveolar cell is making those viruses, it's damaged. And that damage, in theory, should trigger an immune response. In the early stage, you can end up with some viral load, or in other words, the presence of a lot of virus examples or living virus, up high in the respiratory tract. So that's going to be those symptoms you have there, like in your nose and throat. It can also happen low in the respiratory tract. So that's going to be low in the alveoli in those cells. And when that happens, that's a whole different pathophysiology that's going on, because down here, you can have a lot of inflammatory signaling, which is cytokines, right? At this point, you understand that. It's definitely cytokines. And because this has an unusual pathology, the time course of this is kind of strange. Inflammatory signaling released by these infected alveolar cells should activate those alveolar macrophages, some T lymphocytes over time, more monocytes come in, neutrophils start flooding in. Here's the thing. As type 2 pneumocytes are damaged in this process, they're also infected, right? They make less of what they're supposed to do, right? They have an actual job. They've been hijacked to make COVID, but their actual job is to make surfactant. So without surfactant, you end up with at least some element of alveolar collapse. This is part of the presentation of the condition with the shortness of breath. It's partially because this person is having less gas exchange. That's why their SATs tend to go low. If this condition gets a lot worse, you end up with a whole other situation in which acute inflammatory processes are taking place down low in the lung, in the lower areas of the alveoli, and you can have flooding as that edema comes in. So pulmonary edema fills alveolar spaces at the same time as you're getting kind of a chronic inflammatory with acute inflammatory happening. The chronic inflammatory aspect means that you start to get some fibrotic processes, and that prevents elasticity of the lung. So now the lung is less able to do its job in terms of a mechanical attribute as well as on a chemical attribute for gas exchange. This is how you end up with severe COVID. At the same time as all of this is happening, again, remember, this is a high inflammatory state. You're going to have the high likelihood of clotting, and in this location, it's a pulmonary embolism. So you have clots on top of flooding, on top of a stiff lung that is not able to function as it ought to. This is a really horrifying pathogenesis. There are four factors that in one paper early on, and this is still pretty accurate, I just updated these slides here. Unfortunately, this is our understanding of how COVID can be so lethal. So it's the four horsemen that make COVID so powerful. The first horseman is that it is a particularly sneaky virus. It has a number of attributes in its cell biology that allow it to evade the immune system when it first gets into the body. Basically, it hides from your toll-like receptors. The way it manipulates those cells that it infects early on reduces the ability of your innate immune system to detect that a cell is infected. What this means is your innate immune response is low early on. Innate immune response is your frontline defense, right? So if that's not happening right off the bat, then you have this virus that's just replicating without anything trying to slow it. And remember that the reason you have so much redundancy in your immune responses is that viruses try very, very hard to replicate as fast as they can before they start getting taken down by the immune system. So COVID is particularly good at sneaking past your defenses. Once the body finally detects it, and it will, it detects a lot of virus all at once. This means that you have a massive cytokine response, and the term for this is a cytokine storm. Remember that the immune and inflammatory responses are highly regulated things, right? We can't have them too active, otherwise we have a lot of problems. And basically, the pathophysiology of COVID is such that when this gets bad, that's a guarantee. So a cytokine storm occurs, and that occurring in the lung means that you have really high inflammation and fluid coming in, right? You get that vascular permeability. And then as the cytokine storm keeps ramping up, you get even more and more pulmonary leakage, and you start losing cells that you need. So you have this inflammatory process occurring. You have gas exchange going down. You have less surfactant, so the lung is more likely to have alveoli that are collapsing. At the same time, this is occurring over the course of days, if not weeks. And so chronic inflammation is happening on top of acute inflammation. And that chronic inflammation is increasing fibrotic processes in the lungs, especially as you're losing type 2 pneumocytes. So you have multiple forces that are decreasing gas exchange in the lung. And so hence you have the helpless lung. At the same time as all of this is happening, you have a massive inflammatory response. Remember that anytime you have high inflammatory chemistry, clots are likely to form. In addition, this is a cytokine storm, right? Really high activity. So complement is also highly activated, and these things in combination mean very high risk of clots. Now you can have them in different ways. Huge, massive saddle thromboses, just horrible pulmonary embolisms, or little tiny microvascular thromboses. Over the coming years, we are going to see more and more coming out about the effect of this microvascular thrombosis damage and what this does to the body. We're already getting some of this information for long COVID. This will come out for the rest of your career. So how COVID becomes severe? You can see it with this chart looking at interferon. So up here, we have an example of a more mild response. So what happens is if you can actually get the immune system to turn on, represented by this blue line that I'm now outlining, then the course of the disease remains lower. However, When interferon isn't able to rise, in other words, the immune activity, the peak here, observe the peak, that's kind of around this guy. It's a little bit delayed and it's not nearly as high. Then you end up with this horrifying course of the disease in which basically it has time to get scary. It is particularly active later in the disease if you have a severe presentation in the lower respiratory tract, and that's where it's particularly dangerous. That's how we arrive at the condition of ARDS, which you've learned earlier, acute respiratory distress syndrome. What you have is this highly inflamed, flooded lung tissue that cannot perform gas exchange. That's how you end up with ARDS. So again, you have an excessive immune response to create a cytokine storm. You have this hypercoagulable state. What can happen here is those vessels that are supposed to be transporting whatever oxygen they can get, they can't as much now because you're ending up with vasoconstriction as a result of this pathology. This is compounding the hypoxemia. So all of this in combination, these PEs, which are dangerous if not lethal, in combination with ARDS is how you end up with this really severe condition. Let's observe again. This is me re-emphasizing again. So early on, the green line represents viral load. Here, notice how it peaks really early. This is like day 1 or 2. It peaks in the green here in the upper respiratory tract, okay? This is upper. But this purple spike here, this is high activity that is in the lower respiratory tract, and that's the dangerous stuff. Note this time point here. This is crossing week 2 here, right? So here's 7-ish days. In the second week, this is when people tend to admit to the hospital. They've had the mild symptoms, the coughing, the sneezing, the runny nose, and suddenly they're short of breath. This is what tends to get people to go to the hospital, okay? They're short of breath and whatnot. This is because the viral load in the lower respiratory tract is starting to rise. That's pretty scary. So this is what's so dangerous, right? If they can't get this under control, then you end up with that ARDS presentation. So this is why vaccination and boosters matter so much. It allows the body to detect the problem earlier. Remember that the adaptive immune response can call help, right? It can call other elements that will help magnify its effectiveness, such that this is data for February 2023. February 2023 marked an interesting time point because at that point we were into Omicron, right? BA4, BA5, those are variants of Omicron. And at that point, many people had the vaccine and the booster, okay? So the mutation rate of COVID is so high that that's why they had to come up with boosters. So if you had the vaccine and the booster at that time, you were 14 times less likely to die than a person with no vaccination whatsoever. If you had the vaccine and no booster, then you were 2.6 times more likely. So that's still a lot better, right? But you can see that boosters really matter. I mean, that's not a happy number at all. So again, the key here is to allow the immune system to detect it earlier. If you're vaccinated and no booster, your immune system picked it up, but later than the folks who were vaccinated with booster, and much, much, much later for the folks who were unvaccinated. The immune system could not detect it in time, and that's why it was able to get to those more severe manifestations, more likely, without the immune system, the adaptive immune system, able to detect it. Because one of the really frustrating things is that even if you get exposure, even with vaccination, all of these factors, immunity wanes. And so that's because of the mutation rate. Again, remember this class of virus. This is an RNA virus known to mutate rapidly. This is why we're going to see boosters for many, many, many years to come. One thing to note, and this is normal, as of January 2024, if you did not get a new vaccination in the fall of 2023, you are not vaccinated. So you might be like, oh, I had a booster sometime in the summer or something last year. Yeah, no, that's no longer current. Again, the mutation rate on this thing is so high. Those boosters from spring 2023 are no longer being given out because they're not current. They came out with an entirely new vaccine, okay? So as of January 2024, if you haven't had anything in like 6 months or so, you are not fully protected. So keep that in mind. You need to go get the new vaccine. Let's jump into presentation on this now that we have a sense of it, okay, of what's going on the inside. Mean incubation period is still 4 to 5 days. In other words, that means you won't look like you have anything wrong. And then the symptom onset begins. If you're going to get severe attributes, it tends to happen approximately 1 week after the onset of symptoms. So that's 5 plus 7, okay? That's not 7, that's 5 plus 7. So again, that's about 2-ish weeks after the initial infection period. So this is why you had to go into quarantine for a while. We're basically looking to see what's happening, right? And this is also why a lot of times those at-home tests didn't work. If you took it too early, you didn't have enough viral load for it to detect. It had to build up for a minute to see if it was there. It's just the nature of that at-home technology. If you went to the physician and they did the fancy test that took a couple hours, that's more sensitive. But the at-home tech needs a minute for it to work. Okay, I do want you to note the 3 most common signs and symptoms: fever, cough, and shortness of breath. Interestingly, we're seeing more headache. Omicron brought more headache in manifestation. Earlier on, you may remember getting it back when it was Delta, back in like 2021 thereabouts, and that had more of the runny nose, the nasal decongestion. We're not seeing this as often, and thankfully it looks like the recovery rate was a lot better. So that's anosmia, that's the loss of your sense of smell, or ageusia, the loss of your ability to taste. It looks like that actually came back pretty well. One thing I want to keep in mind is that if you were getting these are cranial nerve signs and symptoms. That's an indication of a neuropresentation of COVID, which is scary to think about, but that does mean that COVID at some point entered at least some elements of your peripheral nervous system. So there's a lot of manifestations of this condition, which is what makes it so challenging to kind of survey. For the purposes of this conversation we're having right now, we're going to focus on the lung-related attributes. When we go into other conditions, we'll talk, or other organ systems, we'll talk about more of the neuropresentation of COVID. So there's asymptomatic, which is kind of its own thing. There's mild, moderate, and severe. And then there's all the things that happen outside of the lungs, which basically is pick an organ system. Seriously. If you want to find out more about that, feel free to ask me. I have plenty of papers running around to give you more detail. But we're going to focus on these ones right here, okay? So just to give you a sense, everybody goes through the pre-symptomatic phase. That takes approximately 5 days here, okay? And then you enter different fates. So you can stay asymptomatic, which is apparently approximately 1 in 5 people. So these are the people that we joke are carriers. They don't seem to look like it. And this honestly, a lot of times is kids. I know for myself, that was absolutely true. If I had to guess, so I've had 5 confirmed infections with COVID, and I suspect there's a 6th, and it was a false negative on testing. I'm pretty sure all 5 of mine, my daughter brought home from school. That's just the way of it, right? And each time she either was asymptomatic or it was like a mild cold and she was tired and slept a lot for 2 days, and that was it. So nothing to really write home about, but for me being, older than a child, I entered more of different phases. You may have as well. So these are the other things that tend to happen, a mild, severe, or critical illness, and you can see the time frame in which these things tend to manifest, right? So let's go ahead and continue. I might come back to the slide to refer to it. It's a nice summary of the 3 severity levels if you're not in the asymptomatic category. So again, asymptomatic, you're positive when we do testing, but your chest x-ray looks fine and you have no signs and symptoms whatsoever. Yay for you. Mild, okay, this is what the majority of people have, truly. So these are all the things you would associate with an upper respiratory infection. But you might have had some of the more neurologic things, such as headache, the loss of taste or smell, and then you might have some of the more other organ systems, such as nausea, vomiting, diarrhea, things like that. And then one of the classic signs and symptoms is the muscle pain. The muscle aches are extraordinary. That's a classic viral issue, but it's pronounced in COVID. However, this person will not have shortness of breath. So just to reiterate back here, shortness of breath should not manifest in what we define as a mild illness. It does manifest in a moderate illness in which this person has attributes of pneumonia. So the cough and the shortness of breath are classic respiratory symptoms for moderate, and these are elements of pneumonia. The persistent fever and cough tend to manifest as well. However, they do not have lower oxygen levels on testing. So you put a pulse oximeter on these folks, they are not low on SATs. Now, they will show findings on a CT of the chest. In kids, they tend to have really high respiratory rate rather than shortness of breath. Remember that their vitals, their normal and vitals is different from adults. Severe, this tends to be a hospitalization status, right? This is a fever. They're going to have severe shortness of breath. They don't always have the fever, mind you, but they will have the shortness of breath, and they're going to be frightened by this. They're going to be anxious. This is respiratory distress. It's not unusual for this to start to enter kind of that air hunger thing that we've talked about, in which the person is really, it's the only thing they can think about, is that they are so short of breath. Their respiratory rate is very high. It's in the 30s or plus. Not unusual to see 40s with this. I mean, that person, think about it, 40 breaths in 1 minute, that's going to give you anxiety, right? So they are low on saturation. So this one does have hypoxia, this status, this severe status. So this is pneumonia with hypoxia, below 90% on saturation. If it's a child, they may start to get a little blue. So this radiologic imaging is usually more so to know that other things aren't going on, because as we learned, PEs are really common, but this diagnosis is clinical, okay? So you can also enter a critical state, because there's kind of like levels of severe, right? So there's the kind where you need like oxygen support, but then there's the kind that's more critical, and this is where we enter these particularly terrifying things, such as ARDS. So at this point, we're going to go ahead and pause, and we'll talk more about ARDS in the next section.